Bismillah ar-Rahman ar-Rahim. Ladies and gentlemen, you are most welcome for tonight's talk, which would be about ECG changes in arrhythmias. The important topics, last time we talked about myocardial infarction, and this time about life-threatening arrhythmias, mainly ventricular tachycardia and ventricular fibrillation, and torsade de poids. So just to remind you, this is the normal strip of the ECG with the normal P wave, QRS complexes, ST segment, and T wave. This is how the normal one looks like. We would be starting by ventricular fibrillation, and this is one of the life-threatening arrhythmias, the most important one, and the commonest cause of sudden death. And usually it complicates acute myocardial infarction. That's why the rate of sudden death is almost half of the patients in the United States, like 500,000 die per year annually because of sudden death due to acute heart attack. And also in cardiac impulse, in patients with cardiac problems like valvular heart disease, congenital heart diseases, patients with cardiomyopathies are very much prone to develop ventricular fibrillation. Patients with prolonged QT intervals and patients with post-cardiac arrest, they are very much liable again to develop ventricular fibrillation. You might find longer lists than this, but those are the most important ones. And usually the QRS complexes are wide, bizarre, disorganized, and dysynchronized. And this is how it looks like. Actually, quite characteristic. If you see it once, then you would never miss it. This is again ventricular tachycardia with some runs of torsade de poids. When you find the axis changing, those are the torsade de poids. So you would find high amplitude and then lower amplitude QRS complexes. And all of them are large, bizarre, widened, disorganized, and dysynchronized. This patient has wide complex QRS complexes, but what is happening here, they are regular. It's only on the second line that there is a run of ventricular fibrillation. So those are consistent with ventricular tachycardia, or what's known as VTAC. They are quite large and regular. So what's the treatment? The treatment for both, actually, particularly when the ventricular tachycardia is appearing in a patient who is hemodynamically unstable, and ventricular fibrillation, both are known as shockable rhythms. So when do you shock? If the patient is having ventricular tachycardia with unstable hemodynamic status. The other one is ventricular fibrillation. So we have to identify those patients early on so that we can deal with the clinical scenario before it happens by implantation of ICD. And the clinical presentation of VF is usually loss of consciousness, dizzy spells, nausea, vomiting, acute chest pain, severe shortness of breath, and then the patient loses his consciousness. Also, patients might have acute coronary syndrome. They might have cardiomyopathy, congenital heart diseases, hypertensive heart disease, and valvular heart disease. All are prone. Regarding ventricular tachycardia, as we have mentioned, they are regular large QRS complexes. And the importance of this tachycardia is that it's one of the forerunners of ventricular fibrillation and sudden death. Hence the importance of realizing, identifying, and treating this patient, this type of arrhythmia in a timely manner. So it's shockable rhythm if hemodynamically unstable. If hemodynamically stable, then you are going to use medications for the treatment. The mortality rate, as I have said, 17% in hospital and 47% outside the hospital. This is a run of ventricular tachycardia, regular large QRS complexes. Again, large QRS complexes. And those slides are all from Google Slides. How do we prevent? We prevent by identifying patients at high risk of developing those serious arrhythmias, those patients with coronary artery disease, congenital heart disease, cardiomyopathies, those with family history of sudden death. And the prevention is usually by provision of automated external defibrillator in public areas like universities, schools, markets, any public places, it should be present. And of course, for the appropriate patients decided upon by the cardiologist, then you would go for implantation of intracardiovert defibrillator, which reduces morbidity and mortality in such patients. What are the indications for ICD insertion? The first indication would be those who survive ventricular fibrillation and ventricular tachycardia. Patients who survived heart attacks and patients who are post-cardiac arrest status. Heart blocks, prolonged QT interval patients, patients with Brugada syndrome, and this is one of the syndromes that we are going to discuss later with the ECG syndromes lecture, and patients with congenital heart disease, cardiomyopathies are probably the most important ones. Up next, we are going to discuss ECG syndromes. See you, and I'll be waiting for your comments. Please subscribe and share. Thank you so much.